Good evening and welcome. I'll be giving the first part of the talk. It's always nice to see a lot of familiar faces in the crowd, and of the people who do come that I've had the, I'll say at some points, the misfortune of meeting, because I've often met people at some of the worst points in their or their family's lives. It's nice to see some smiling people and some successful stories, and I'm always happy to have people greet me and remember me fondly from a horrible time of diagnosis. I'm a gastroenterologist. I've been at Hartford Hospital for 11 years. In the realm of pancreatic cancer, as I was just describing to one of the people outside, I'm usually the person that's there when the bomb goes off. Right when the explosion has just gone off and the smoke is still there, unfortunately, I end up meeting people at the moment where they have gotten their CAT scan or they're symptomatic and they're coming to find out what is wrong, how bad things are, what type of growth this is, what the extent of it is, and through somewhat of a disjointed healthcare system sometimes that things are organized by medicine, surgery, oncology, radiology, my job is oftentimes to escort people to the people they need to be seeing by finding out what's wrong. An oncologist, for example, would not want to see someone that they don't know that this is a tumor or a cancer. A surgeon wants to know a person that they need to do an operation on. A radiologist would want to know who they need to do distant staging on. And somewhat of my job is kind of getting people to the right people at times and helping facilitate that. Pancreatic cancer is very common in the media. What do all these famous people have in common? And you can say, hey, we all know their names. Some are men, some are women, some are known for their looks, some are known for their intelligence. Some are known for their achievements in entertainment. But what all these people have in common is that they've all died from pancreatic cancer. And we see these names in the news and in the papers, and I think we most commonly think of people who might have died from them, like Michael Landon was a very famous actor. Patrick Swayze is what most people think of. But they don't think of Ruth Bader Ginsburg as a Supreme Court justice who is alive, working, and contributing actively. We know Randy Pausch from the last lecture. If you've ever read the book or seen his YouTube video that they made, he was a professor at University of Pittsburgh, gave a lecture about outlooks at the end of life. Very few people have given outlooks on success. I was watching a Center Stage with Charlie Sheen. Sounds strange, but they were interviewing and they said, "What problem did you initially have when you were young? You were in Wall Street, you were in Platoon." He goes, the problem was, they always say, if at first you don't succeed, try and try again. No one ever tells you what to do if you at first succeed and don't know what to do with it. And it's kind of a comment that stuck with me is, no one knows what to do when things go well. And where are we 5 years after a serious diagnosis? Everyone's prepared for the worst, or what's my worst case scenario, but no one ever thinks of the best case scenario when things end up happily. And that's unfortunate with this disease. We get pushed into that and pushed into doom and gloom and not into optimism and saying, as hard as it is when you first meet someone, what are my likely outcomes? Well, the data will say that at 5 years' time, the five-year survival at 5 years' time is 5%. And what I commonly say to people is, we always think of the 95%. We don't say, well, what's going to be special about me that I'm going to be that 5% of person? And there's nothing about me that should tell you that I'm not going to be that person. It's the fourth leading cause of cancer-related death in the United States. Lung cancer, breast cancer, colon cancer outpace it. And it's the third most common GI-related cancer, following colon and esophageal. The mortality rate, the rate that people die, closely follows the incidence rates, so that as many people are getting diagnosed with it within the year are the same number of people that are dying from it within that time. The overall 5-year survival of all comers, because people present at very different stages, some people early, most people more advanced or later stage, is 3 to 5%. Surgery currently is the only potential curative treatment to find it at an early stage that it can surgically be removed, and cleared of tissue is the one chance we have of curing this. If people are diagnosed at the time where it has metastasized or spread to other organs, to liver, or it has connected itself to any major blood vessels, that it cannot be cannot be removed, it's a very different outcome and a very different survival. 15 to 20% of the people present at the initial time of presentation when, and we'll talk about what some of the symptoms are of how people come to know they have pancreatic cancer or pancreatic disease. Only 1/5 of these people have this potential to be candidates for pancreatectomy, for surgical resection, and for permanent cure. And this is a slide showing some of the rates. And when you hear of how common prostate cancer is, the 5-year survival for this is 99.8%. Most people diagnosed with prostate cancer will die of something else. Very few people die of that disease. Are there people? Absolutely. But for the most part, it's a disease of men as we age. Heart disease will intervene, and other things will come in the time. Thyroid cancer, similar. Another disease will kill you. Melanoma confined to the skin, and that's a little tricky one as well because of its ability to metastasize, but limited to the skin, 92%. Breast cancer, of which we hear so much in the lay press and gets so much attention and so much fundraising, and is a horrible disease. Overall, currently, with the changes in technology and research that we've discovered, receptor status and susceptibilities to chemotherapies and better operative techniques, the 5-year survival is 88%. And as we come on down, colon cancer, in the last 10 years, screening colonoscopies have become so prevalent that everyone knows at age 50, you should be having a screening exam to look for polyps that if they had been left alone, if you were to have them, would develop into cancers in 10 to 15 years. By doing screening colonoscopies, we have downstage disease. The people who have diagnosed with colon cancer are getting found at earlier stages, less chance of metastasis, and that's had a direct impact on 5-year survivals. Pancreas, unfortunately, remains at this 3 to 5%. Top 5 funding cancers by the National Cancer Institute. This is a little bit of an older slide, but just still shows the same point. If you look at the millions of dollars from federal government, and then there's another slide or more information from private funding, lung cancer rates have gone up. All the funding has gone up, but if you look at where pancreatic cancer is in millions of dollars from the National Cancer Institute, it's far below prostate, breast, colon, and lung.
Why?
That's a very good question. I don't have a definitive answer for it. Some of it is marketing. Breast cancer, and it's not to belittle or anyone else's plight with things, but breast cancer has had a very effective marketing strategy of saying everyone knows a woman who's been affected by this. And it pulls on people's heartstrings, and you might not have that same tie marketing-wise or advertising-wise with pancreatic cancers. But I think it's mainly marketing and knowledge and political power. Some of the presenting symptoms, and there can be a whole variety. They can run the whole gamut from, but most people who seek attention have had unintentional weight loss, a loss of appetite. Some people have abdominal pain in the middle part of the abdomen that classically could radiate to the back, nausea or vomiting, jaundice or yellowness. Mainly depends on where the tumor would develop. If it's in the area of the head of the pancreas, that would block the bile duct, which drains your liver of its bile. You will get jaundiced. And then some people present with new onset of diabetes. Not the type 2 diabetes that's very closely associated with obesity, which is called insulin resistant, but more insulin dependent diabetes. If you look at just some brief anatomy, and Dr. Jimenez in some of his slides will have more of the anatomy because he's going to be talking about surgical resections and treatments, but just a general lay of the land. Your pancreas is an organ at the back of your abdominal cavity. It's about the consistency of a flounder fish. It has a spine that's the duct that drains the pancreas juice. Pancreas juice will help you break down fats. It's its main digestive function. Interspersed in the pancreas, you'll have these little cells, little islet cells that are the insulin-producing cells. But by bulk, by how much tissue is there, most of your pancreas is a digestive organ that makes pancreas juice. Your bile duct, your liver would be up here. Your bile duct is like a little tree root that you pull out, that little ducts become bigger, and form a common bile duct that goes down through your pancreas and empties into your duodenum. That's the first part of the intestine that's there. And they both empty at this little nipple. When you have tumors or growths in this head part, it'll compress that bile duct, and that's who would get jaundiced. So it's where the tumor happens. If the tumor happens in the tail or body, away from that bile duct where you would not turn yellow as a result of it, you are found to have a growth generally larger in size because it hasn't drawn itself to attention. You can have a very small tumor in the head of your pancreas that compressed that bile duct, and you are fortunate that you got the yellow warning sign. Your eyes turned yellow, your urine turned dark, or your stool turned white, just based on where it is, and you find it at an earlier size. CAT scanning. A CAT scan is a machine, it's like a big donut that you lay on a table and cuts you like lunch meat. It takes sections of you every 5 to 10 millimeters and will make slices, and then they assemble these slices. When you get up to the mid-abdomen level, and this is to give you some perspective, here's the spine laying on your back, feet looking towards your head. You will see the pancreas is here's your abdominal cavity right here. Your pancreas is all the way at the back of your abdominal cavity. It lies over the spine, it flops over the spine. There's your vena cava, which is the blood vessel that drains all the lower body of its blood back towards the heart. Your aorta brings blood to the lower body and abdomen. So you're lying over that, tucked up underneath the liver. You have a duodenum that wraps around it. So it's in a very tight little place all the way at the back of the abdomen. Tumors can happen anywhere. Typically, like I said, they'll be larger in the body and tail on presentation by the time they become symptomatic versus in the head, because you won't get the yellowness associated with it. This is a little picture of an ultrasound with a needle going into it. To look back at this slide, since your pancreas is all the way at the back of your abdominal cavity, it lies underneath your stomach, underneath your intestines that are all in the front of your abdominal cavity. This pancreas is all the way at the back. A very hard area to get to. So when people were trying to do biopsies back in the day, they would put you on a CAT scan machine. They would take a needle, go from the outside, they'd advance the needle in, take another CAT scan picture, advance the needle in, take another CAT scan picture, and inch it towards this area in stop action, centimeter by centimeter at a time, and try to do a biopsy of something. CAT scans can see tumors greater than an inch, 3 centimeters, inch and a half. So someone, very gifted person, thought of miniaturizing an ultrasound probe and using the stomach as a window to that back of the abdomen. Since we know the stomach lies on top of it, if we put someone to sleep and put a camera down through their mouth and put an ultrasound probe against the back wall of the stomach, we are less than 1/4 of an inch away from your pancreas. We've taken a shortcut, and we can then get pictures by using, just like you take a picture of a baby or a gallbladder from the skin, we rub it against the back wall of the stomach and get very good ultrasound pictures of the pancreas, and then we can place a needle directly through the stomach wall to obtain tissue. Because that's the main thing, is not just that it can look like anything on a CAT scan, but we have to get that biopsy proof. We have to have them look at it under the microscope and show that there's cancer cells or not in it. And this is what this scope will look like. It's about as wide as your index finger. It's got a little ultrasound device on the tip of it. It has a little channel where the needle can go into things, and we can easily traverse that stomach to get into this tight, small space and get better pictures and get the tissue that they need. What are the risk factors for pancreatic cancer that we know of? Chronic pancreatitis is an inflammatory condition of the pancreas where it is inflamed and scarred, inflamed and scarred in a cyclic pattern until you get bad scarring. We don't know with a lot of diseases why recurrent injury, repair, and scarring does lead to cancers or makes it more prevalent, but we do know that cancers in chronic pancreatitis are more common. Cigarette smoking is probably the one major risk factor that we have any control of changing, that we know of and we can change. Everyone knows about the risks of lung cancer in smoking. Again, we're talking about funding, advertising, politicking. Everyone knows that. Very few people know that smoking is a major risk factor for pancreatic cancer. Not the sole cause of it, but a major component. But we know that smokers have a markedly higher rate of pancreatic cancer. Increased age. We don't typically see pancreatic cancers in people less than 45. We have, they're rare, but it's more of a disease of 50s, 60s, and 70s. Obesity. No one knows the reason, but it's more common in people with higher body mass index. More common in diabetics. Some occupational exposures that are not much DDT around anymore, not much benzodiazepine around. And there are then certain ethnic groups. I'll be honest with you, this is from my reading and my research preparing for this talk. I haven't treated many Hawaiians, but for some reason, Native Hawaiian females have a higher risk factor. People of Ashkenazi Jewish heritage and African American males. And then there are some genetic syndromes which make pancreatic cancers more at risk. I think the main one to concentrate on is the one with the highest rate is a syndrome called Peutz-Jeghers. It's an inherited syndrome of forming these very unusual colon polyps and very unusual kind of dark pigmentation of the lips. Very rare, but notorious for having 100 times increase in the baseline of pancreatic cancers. Hereditary pancreatitis. There are families who many members of the family will have these recurrent bouts of pancreatitis, which is what I mentioned, the chronic pancreatitis. It's just a painful condition, upper abdominal pain, nausea, vomiting, go to the hospital, get a CAT scan, your pancreas is all swollen. You can see it expanded or swollen. High labs that show pancreatitis. It runs in families, and that has a 50 to 100 times increased risk of pancreatic cancer. Why? We can't tell you. Familial pancreatic cancer. I think the most common family that people might know of is Jimmy Carter's family. His brother Billy died of pancreatic cancer at 55. His father and grandfather and one of his uncles all had pancreatic cancer in their 50s.
How is he?
He is 88 years old and looks great. So again, these family syndromes and family histories are a predisposition, not a destiny. So there are many things we don't understand of these mechanisms of why this happens, but it just puts you, being a doctor sometimes is a little bit of an odds maker and saying chances and percentages of things. You will see families and say, you're at increased risk, but I don't know what is different about you versus the family member that had it. There is obviously a lot of things we don't know. Very common one you'll see from, again, the politicking and the breast cancer people, which we're all jealous of from their money and accountability, is the people with the BRCA genes, the BRCA genes, do have an increased rate of pancreatic cancers as well. Again, why? We don't know. We don't know what this BRCA is measuring and why if there's something associated with it, travels with it. But as much as they've discovered as diagnostic and prognostic information with the breast cancer people, if you are a BRCA family, how you respond to therapies, are you at risk for a second breast cancer in the breast that's left? Are you at risk for premature or early breast cancers? We do know that if you have a family with this BRCA2 gene, you are at an increased risk of pancreatic cancers. And then there's what's called a Lynch syndrome, which is a familial colon cancer. Multiple people with early colon cancers in their 40s and 50s are also at risk for pancreatic cancers. We oftentimes diagnose people when these tumors are already malignant and when they're already present and maybe have metastasized to other organs. As I briefly alluded to with colonoscopies, we have screening colonoscopies to detect polyps. Polyps become cancers if left alone. Many people have thought, well, what is a precursor lesion of a pancreatic cancer? Does it just start as a solid tumor and just pop up and we don't know it because it's microscopic and it's left to grow and we don't see it? We can't look inside and look at it directly. We can get ultrasound pictures or CAT scans of it, but we can't look at it like an ion view inside your colon. The one thing we do know of that is a risk factor are certain cysts or collections that happen on the pancreas. So there are some pancreatic cysts that are found very commonly on routine imaging. Someone getting a CAT scan done because they think they have a kidney stone. Someone with abdominal pain that's not related to this will find an incidental thing that there's a cyst in their pancreas, and that could be a risk factor for developing a cancer there. So that is one of the precursor lesions that we sometimes see. And there's certain types of cysts. Not all cysts become cancerous. Not all cysts have the potential to, but some do. And by studying them and doing further testing on them, we can see if they're one of these precursor lesions or not, based on if they have mucus inside them. Mucus is usually made with tumor-producing things. If it is serous or water-filled, it has a very low risk. if it is what is called a pseudocyst, which is a complication of this pancreatitis disease, where your pancreas is swollen and then forms a swelling and a fluid collection on it, there's very little to no risk of pancreatic cancer for that. But if there's mucin in it, or it is of a dilated part of the duct system, that this duct is making more mucus than it should, these are risk factors that we have to look at. We don't know how to split these up. We don't know what would make one of these mucinous cysts become cancerous or not. There are different genes that are expressed in these cells, and what they're called are mutations, where a cancer cell is your own cell that has turned its replication on and keeps dividing out of control. All the cells of your body are constantly dividing, but they divide usually when it knows it's going to die. It makes its duplicate, and then the survivor takes its place and does its function. A cancer cell loses that ability to know when to divide and when not to divide, and it just divides all the time, and it keeps duplicating and doubling, and it has a very fast rate of growth. Well, there's some genes that will basically delete or make a mistake, and this don't replicate will be lost or shut off, or there'll be one that will make it always replicate and go on. So it's a mistake of either. So we don't know, what we don't know, especially in these cysts or in tumors, is this cyst that's growing, did it have this mistake the very first day it was born, and that's why it becomes cancerous? Or does this cyst turn to a large size? It starts small, it grows to a certain size, and then this mistake happens and it accelerates and grows from that point. We don't know its life cycle because we haven't seen a lot of these lesions or gotten material out of them or studied their cells, because we haven't, until recently, been seeing things in their infancy like this. So it's only recently that we've been seeing these cysts, because the imaging is getting so much better and finding these things at smaller and smaller sizes. It's a blessing and a curse to get an incidental CAT scan and find one of these little cysts, because most of the time they won't turn into anything, but it gives a lot of angst and a lot of worry. But you're also possibly seeing something you can alter the future. So like I said, it's a blessing and a curse all mixed in as one. So what we're talking about, some of these precancerous lesions, and there's this intraepithelial neoplasia, which occurs in some of the ductwork, the small branches of the duct that we can't see that well with current imaging. And then there's some of these mucin-containing cystic lesions along just of the parenchyma in the gland itself or in the ductwork itself. The main branch, that main spine duct, the spine of the flounderfish we talked about, if there's a mucinous cyst of that main duct, it carries a 70% risk of progression to cancer. If it's in the side branch, it has half the risk, about 30%. So we take these cysts very seriously when we do see them and do investigate them, and we watch them very closely. Because in a disease with such a bad outcome, if we can see a precursor lesion and we follow it, we can see it at its earliest change site and intervene before it becomes cancerous and have it removed. Who is the appropriate person to remove it is the key question. Because if it's a cyst that has no potential and you're going to put someone through an extensive surgery, what does that accomplish? This might be something that might not have ever become anything. On the converse side, this might be something you've altered history dramatically and changed them from ever having a horrible disease.
Is the only way you find these things by accident?
Well, a lot of them are found incidentally. A lot of them, unfortunately, are because, why would you have this CAT scan? Why would you be exposed to this radiation unless you had a reason to, or this MRI? Why would you be getting this? If you had certain abdominal pains, that would be more symptomatic driven, but many of them are found incidentally at that kind of stage. So again, another ultrasound picture of this ultrasound probe in the middle of the screen, pancreas tissue, and a very big dilated duct with a ball of this mucus right inside it. So we're seeing this before it's cancerous. The duct itself is 3 or 4 times its size, and it has one of these mucus balls right in the middle. We see that very clearly, because if you look at it, this circle size from here to here is only about a ½ inch. So that's like a yardstick of what it is. We are within a ½ inch of this duct in this pancreas, and this mucus ball is 3/4 of an inch. So we're looking at things that are very, very small, blown up on these big screens. But it's using this ultrasound probe, it's the proximity we are and how close we are to it. But we can see these very subtle, small changes. All cancer cells are not what's called adenocarcinoma. That's the most common of these, but some of these are called neuroendocrine tumors as well. As I said, the pancreas gland has a lot of digestive cells, but it also has a lot of little endocrine cells, insulin being the most common of the endocrine cells. So there are tumors of these insulin cells, and they present with different symptoms. Symptomatic hypoglycemia or low blood sugars, episodes of confusion from low blood sugar, even passing out, sweating, weakness. There's a tumor called tumor that makes gastrin. Gastrin helps you make stomach acid. It's one of the signals, but the tumor itself starts in the pancreas. And they present with very bad ulcer disease and diarrhea. Glucagon is the opposite hormone of insulin. Insulin lowers your blood sugar. Glucagon rises it up. So people present with diabetes, weight loss, and diarrhea. So there's many other little endocrine cells dispersed throughout the pancreas that can go wrong. They've come to in the public relations world, this is the tumor that Steve Jobs had, was a neuroendocrine tumor. And it's thought to be less malignant or less aggressive, but also, as we know from Steve Jobs, it had metastasized to his liver and he ended up dying from it. So less malignant doesn't help when you're the one that has severe disease. So how are we going to improve patients' outcomes? What are we going to do? You can see over the last 20, 30 years, and when Dr. Jimenez speaks, he'll talk more about treatment and therapy. It's very discouraging to show that with many of these other diseases, colon cancer, like I briefly alluded to, breast cancer, their survivals have all come up with funding, research, technology, detection, screenings. How have we made no progress with this disease? Why is that? Because we haven't come up with a good way for earlier detection of finding these things when they are very small. Because it's all the way at the back of your abdominal cavity. It's not a thing you can handle. It's not something that you can palpate on your body. It's not something you can say, hey, look at this mole. It looks a little funny on my arm. Maybe I should get this checked out. When they're in their infancy, you'll never even know you have it when it's tiny. When it's 5 millimeters, 10 millimeters, you'll never know you have it. So we have to somehow come up with an earlier detection, and somehow we have to improve the staging, which is an accurate guide to preoperative assessment to knowing if it's resectable or not. And we've made lots of progress in that in order to avoid an invasive staging surgery. Back in the old days, staging meant you have a tumor, someone was going to open your abdomen, and they were going to handle it and touch it with their hands and see what else is it connected to, what else is involved in it. This is, Dr. Jimenez, maybe 20, 30 years ago? The hands never lie, right? Well, if we can do staging to see, what's the worst thing you can do? You're going into the hospital and you think you're going to get something treated, and an operation which Dr. Jimenez will tell you takes 6 hours, 8 hours to do. The doctor comes and talks to your family in 30 minutes means nothing good has happened, or he's found something that no one has wanted. And that was more common before. As we do some of these other stagings, we can guess who, or sometimes we guess, sometimes we know by seeing the blood vessel involvement, areas of the liver, areas in the abdominal cavity that we know we don't even offer people like that surgery because we know they're not going to have it able to be resected. So we're better at telling who that is. I think one of the key points to remember is high volume centers. Since this pancreas is in such a tight space in the back of your abdominal cavity, this is not something you want done at a small hospital that will see 1 or 2 of these a year. You want to concentrate the experience and go to places that deal with this, see this very commonly. And Dr. Jimenez, I'm sure we'll talk about what a high volume center versus a low volume center is. But it's not a hernia or gallbladder operation, not to bullet anyone that does that. It is something that you want someone that has a large amount of experience and does it continuously and sees this commonly. There's an inverse relationship between case load volume and perioperative mortality. The more cases you see, the less people die as a result of the surgery, and vice versa. If this is something that's a big event at the hospital and they only do 2 a year, that's not where you want to be. You want to be where this is a routine thing and they do it all the time. When we talk about screening, what we said, what's the one thing we can do? Well, we can try to find things at an earlier stage or see at-risk populations. Unfortunately, 90% of the pancreatic cancers are sporadic, which means there is no warning sign. We don't know it. They didn't have a family history. They didn't have any of the risk factors. They weren't smokers. At this point in our limited knowledge, is left to the doom and gloom of bad luck. I don't know why you have this. I don't know, you had none of the classic risk factors and you are a nice person that something bad has happened to. And that's all too common that we say that. Pancreatic cancers are relatively rare. We all know someone that's had one. There's many people that have had family members here or have personal experience with this. But for the most part, it doesn't have that 1 in 9 that the breast cancer does. You know, it's a lot less common than that. So that being the case, population-based screening does not make sense on a population level. When you do colonoscopy screenings, and you'll see in the newspapers and the press and Time magazine, people debate this constantly, and people debate mammograms and PSAs constantly. Why would I spend X amount of dollars on a mammography if I know it's going to be abnormal this percentage of the time? 95% of the people is going to be normal, but I just spent all this money to find the 5%. And what is the value of the dollar per year of life saved? And this is more the realm of politicians and insurance makers and corporations. For how rare pancreatic cancer is and how invasive the screening can be with CAT scans and radiation, it does not make economic sense to put everyone through it to find it. But what is an evolving field is selective screening of high-risk groups is reasonable. There are no formal guidelines. There are no, you have X, Y, or Z, or you have this many people in your family, then you need to get this. There's not a formal guideline like that. There are recommendations from larger volume centers. When would you start? You know, someone will say, it's a very common question, someone will say, my 50-year-old father had pancreatic cancer. What do I do? Do I start now? Do I start at 40? Do I start at 50? It's a lot better understood population-wise with colon cancer. We know from colon cancer, if you've had a first-degree family member with colon cancer, you get yours at 40 or 10 years younger than the person in your family who had it. It's that there's a national guideline. It's been studied in databases of tens of thousands of patients. Okay, I've done your screening exam. It looks great. I did an endoscopic ultrasound on you. I did a CAT scan on you. Well, when's the next time I get one? Do I get it next year? Do I get it 2 years from now? Do I get it 5 years from now? We don't know. What is the best test to do? They all have pluses and minuses. Which is the right one? Which is the most sensitive, the least invasive? So there's many uncertainties in this whole field, which is frustrating. What we do know is how to improve outcomes is, and it's sad to say this, and it's true, but the medical systems and medical schools were set up in 1910 based on a thing called the Flexner Report, and that set up what goes into a medical school. And let's split diseases into, well, the first split was your surgeons and your internal medicine doctors. You either cut things open or you treat it with medicines. That was the first earliest split. And we're still stuck in that. It's changing. But what that means is things are coming more to a circle of forming a disease center or an organ-specific kind of thing where there'll be numerous physicians in different trainings that are interested in pancreas. Dr. Ahmed is very interested in pancreas. His training is extraordinarily different from mine. I don't know. I know what he does. I have no idea how to do it. I don't have any idea what's really involved. We see patients in common. I know from talking to him, from learning from him, what he's doing. So when I do talk to patients, I can give him a realistic expectation of what I think he's going to say to them. But I don't know how to do what he does. He doesn't know how to do the endoscopic ultrasounds I have. There's not one doctor that says, I take care of pancreas and I can do everything related to this pancreas. It's not the way we're trained. So you need a gastroenterologist that'll do some of the diagnostic testing, a surgeon experienced in pancreas surgery. Not every general surgeon will do this. A medical oncologist, doctors who give chemotherapy. A radiation oncologist, a doctor that knows the physics of how much radiation do I need to give and what kind of beam and where and how to locate it. I don't remember much from physics. Made me take it, I don't remember it that much. A pathologist, someone who can say, I know you took this tiny little needle and took a poke of this tumor, and I can tell you there's cancer cells, and I can tell you this is cancer. Very talented to tell from such a small sample. We're not getting this thing out at the diagnostic stage and holding it in our hands and saying, look at that, it looks like a tumor. We're taking a needle and poking it. And there's a doctor that's extraordinarily trained to say, I know because it turns certain colors with certain chemicals and the cells look this shape and the nuclei, the little center of it looks a little oblong or a little large, are going to tell me this is cancer and that you should be getting this therapy. A radiologist taking a look at these images and saying, you know what, this is a swollen pancreas and this is a swollen pancreas with a tumor hidden in it. You know, you're asking people, it's very specific training and very different trainings that we've all learned. So you need people with experience in all different facets of it to kind of come together and treat it as one common disease. What I do is mostly diagnosis and staging. And the staging is very important to determine what the most appropriate therapy is. We know if you have spread to your liver metastasis, or it grows into one of these largest blood vessels, that this cannot be surgically cured or surgically removed. One of my major jobs is to help split those people into this resectable and unresectable by doing this ultrasound and seeing it's involved in this blood vessel, or reviewing the CAT scan with the radiologist and saying, hey, there's tumors in the liver, we should biopsy one of those to prove that. But it's not going to help anyone if I take a patient with liver metastasis and send them to Dr. Jimenez and say, hey, do you want to do an operation? We know that's not going to cure them. We know they're going to go through an operation and not going to have any further benefit from that. So the staging, telling where it is at the time when we're finding out about it, is going to be key to give prognostic information, what's going to happen to me and what kind of time frame, what can I expect. We know that surgery can cure 20% of the people. We know that locally advanced, which is connection to a major blood vessel in the abdomen, has a median survival. Half the people survive, half the people do not, of 1 year. And we know that people with distant metastatic disease to either lungs or liver have a median survival of 6 months. Again, odds. Median does not mean your destiny. It doesn't mean any doctor says you have 6 months to live. It doesn't, who knows? It's saying that of similar people that had the similar disease, the odds are that half of them are alive at this point and half of them aren't. That's what we know from the data tables. That's all that's saying. Tumors of this head and uncinate, the top part of your pancreas, present earlier than tumors in the body or the tail because of the jaundice or not. Resectability or non-resectability, distant disease or local disease. Is it just confined to the pancreas or is it outside the pancreas in the abdominal cavity? All things that have dramatic implications for what treatment you're eligible for, what treatment you're going to do well with, and what you should be getting. In the good old days, everyone always likes to reminisce about the good old days. In this, there's no good old days. Resectability is assessed at the time of surgery, hands-on, handling the tumor, palpating the major vessels. It's now advanced to state-of-the-art CAT scans. Thanks to the power of computing and computers, CAT scans in the 1970s and 80s took cuts every 15 millimeters, every 2 inches, inch and a half. They can now do cuts when we ask for a pancreatic protocol CAT scan, they take cuts every 5 and 7 millimeters. So the resolution has gotten so much better so that we can see things at a smaller and smaller size. Endoscopic ultrasound, which is one of the procedures I specialize in, can detect tumors a centimeter in size, half a centimeter in size. MRIs are very good at looking at the ductwork of your pancreas. MRIs are big magnets. It looks like a CAT scan machine, but it's based on magnets, and it sees things covered in fluid very well. You'll hear people getting brain MRIs, spine MRIs, because your brain is bathed in cerebrospinal fluid. Well, your pancreas has that duct in the middle of it, and that duct is perfect. It's all full of fluid. Your bile ducts are full of fluid, and the blood vessels around them are full of fluid. So very good to get pictures of fluid-filled tubes to see if there's an abnormality of the ductwork. Laparoscopy. Sometimes all these tests, for as good as we think they are not as good as getting your eyeball in there. And so laparoscopy is part of a surgery where they will, instead of making the big incision, opening and seeing something more advanced than we thought, they'll put the little camera port in and peek into the belly cavity first to see if there's any tumor outside this pancreas bed, if it's in the lining of the abdominal wall, so that you have a minimally invasive you get a little keyhole surgery, commonly done, as Dr. Jimenez will talk to you, at the time of a planned resection, just as the last fail-safe, like, let me just take one more peek in there and make sure I'm doing the right thing. Other tools are used in the decision-making of who's eligible for what and what's appropriate. A major one is the overall health status of someone. If someone's coming in with major heart disease, has had a stroke within the last year, has major restrictive lung disease or bad breathing, oxygen dependent, they might not be eligible for some of these therapies. They might not tolerate the surgery or tolerate any of these chemotherapies or all these treatments. Can they tolerate a major surgery that's going to last 6 to 8 hours? Other decision-making, ERCP is injecting dye into the ductwork, and it's how we help the liver drain a little better by putting a little plastic or a metal stent in the bile duct to help it drain better. And then tumor markers. There are some blood tests that are make a tumor more suspicious. No one's ever going to treat you based on if you have one of these tumor markers positive, but it makes our index of suspicion higher if those are very high, that we really want to go after and get that biopsy proof to know that's what it is or isn't. CAT scans can see masses less than 2 centimeters, less than an inch, in 77% of the times. It's the best modality, though, to look for areas of distant disease. Very good looks at liver, very good looks at lungs, very accurate at looking at vascular invasion. It can look at, by reconstructing the pictures of the blood vessels, it can see if there's any encasement of the major abdominal aorta, of the mesenteric artery, or of the portal vein which drains the liver back. Here's a CAT scan. It's taken in a different plane. I lied to you before and said CAT scans were taken like lunch meat in this direction. Well, guess what? This slicer can cut you lengthwise too. So it's taking someone and cutting them in this direction. So here's the liver. Here's this portal vein. The portal vein it's full of dye, so it's white, and this would drain all of the intestine's blood back through the liver to be filtered and processed of all the nutrients it gets from food. Well, this portal vein is kinked. It should be this fat the whole length, and it's not. It's not because the tumor is growing around it and has taken this blood vessel and it's gripped it. And that's something that would make that unable to be removed surgically, is that vascular involvement. And this is something we see on the CAT scan. You might not see it in a different cut. If I sliced it in this direction, I might not get that slice in that picture. By getting it in this angle, I see this kink point here, and that has altered what the person has. This would have been found at the time of surgery. When they open the abdomen up and they're exposing all these things to get to this back, they would look at this portal vein and say, hey, this tumor's wrapped around it. I can't remove this. With a CAT scan, in this instance, you know that before they'd even go to surgery, and that's not the right thing to do. Endoscopic ultrasound is the best method to look at the local tumor itself and its immediate environment of the tumor. It can see lesions very small, smaller than a centimeter. It can give you a different look in a different angle. CAT scans are like still pictures. You take one click, that's what you're seeing at that point in time. This ultrasound is done in live action. While the person's breathing, moving, asleep during the procedure, when you take this endoscope and put it down through into your esophagus, stomach, and this duodenum, you're getting this immediate area. If I get an angle I don't like, I can move around it and look at a different angle. I can move on this side. If I'm not sure, I can look at it this way or up above by where this camera and this probe goes in relation to it, so I can get looks in different directions. And we're seeing, there's, just like you see on the weather report, there's Doppler flow. There's a Doppler flow on this, and I can see if the blood is moving in this vessel the way it should be, or is it in a reverse direction? Is it flowing up towards the liver, or is it stopped, or is it whirled up because I know it's narrowed at some point? So it gives us a confirmatory thing to know. We can, our tissue acquisition, when we do a needle biopsy of it, 94% of the time it's accurate. That sounds great, but what if you're one of the 6% of people that aren't? That's why when we do these ultrasound exams and we take a biopsy of it, it's based on the team of doctors' index of suspicion. I really think there's something there. If your biopsy is negative, you're not necessarily in the clear. I tell a lot of people, this means we need to do it again because I'm so worried that this area is cancerous or there's something there. And the price of not ignoring it, but saying, you know what, the biopsy's negative, I bet you there's nothing there. There's that 1 in 20 that it is there, and we just haven't seen it on the biopsy. So most of the time we get the answer on the needle, but sometimes when it's not, it's based on how aggressive you want to follow this and how comfortable you are in saying, you know, there really is nothing there. We're very good at seeing lymph nodes. These lymph nodes are all around the abdomen. They follow these blood vessels, so we can see enlarged lymph nodes around the tumor, in the immediate area of it. We're seeing things that are, most of these lymph nodes are about, we've all had a sore throat and gotten a lymph node you can feel on your neck. It's a little rubbery thing. It's about 1 centimeter in size. CAT scans don't see them very well because it's less than the 2 centimeters where they see. Well, we see them pretty well because they're all next to this duodenum, stomach, and pancreas. So a lot of times we'll have a good assessment of, if we think lymph nodes are involved or not. Ultrasound is very operator dependent, which means I am moving this camera around. Could I have, machines mechanically slice you the same way every time? This is going on how my hand is moving and sweeping around it. When I am suspicious of something, the hardest thing for me to say is that this is a negative exam. If I see it, I know it. But if I look and look and look and don't see anything that the other images have, I'm not necessarily satisfied with that. I'm very disturbed or troubled by that. It's not what I'm expecting to find or see, but it is person to person dependent. There is a human element in it that is not machine-like and doing it the same way every time. It's the same way as cutting a piece of wood and putting it on the table saw and putting the rip fence at 12 inches and saying, okay, every board I'm going to cut today is 12 inches. And me saying, you know what? I could take my saw in my hand and cut this 12 inches every time. I'll measure it and cut it. Well, guess what? On one of these boards, I'm not going to get it quite the same way as if it's fixed in place and cutting it the same way every time. So there is a human hand in it. This is an ultrasound picture of the similar one from the CAT scan. Well, you'll see the ultrasound probe here. Here's the tumor, and here's that portal vein that's pinched in the same way. That portal vein should be a big column that way, the whole way, and that tumor is pushed right up against it like that. We don't see it encircling it, but it's definitely growing into it. So obviously a very troubling and concerning thing. Another picture of the same thing. You can see it for yourself. This is what normal pancreas tissue looks like. It's like salt and pepper, it's like gray. Well, here's this big dark one right here, and it's growing right into that portal vein. The portal vein is like my arm, and it's right in the crook of the arm like that. So you can see it with an untrained eye that these two are connected to each other and should not be. There should be a nice divider between the two, and there's not. So sometimes it's not very subtle when we see it. There should be a fat plane. Some people are fat, some people are skinny, but in the pancreas, there should be a nice plane of fat on the ultrasound. It's a nice little white stripe you see. There should be a normal fat plane between the tumor and these arteries and these veins. If it has this normal plane between it, then it's resectable. There should be no direct extension to any of this celiac artery, one of the major arteries that come off your aorta. There's no involvement in that portal vein. There's no extra pancreatic disease. There's no liver. There's no lining of the abdomen. This little peritoneal cavity has no little studding. There's no fluid in your abdomen that would be tumor tissue or any problems in the chest. That's what defines a resectable tumor. None of these categories involving it. That's going to conclude my part, which is diagnosis and staging. And now we're going to hand the stage off to Dr. Jimenez. He's going to speak on surgery, treatment, and then we might take a little break and then stay for questions.